to India. So this is a very important topic for all of us to how to manage, because this disease was diagnosed way back in 1960, and now in 2025 also we are not able to manage as per the guidelines. Maybe it looks like it's an easy disease to manage, but let's be honest with you, it needs patience to manage, and it needs the constant regular follow-up of the patient, which is very important to know the natural history of the disease. So coming to hypertrophic cardiomyopathy, we all know that it is the myocardial disease. Means it is a disease of the heart muscle, which is characterized by the unexplained left ventricular hypertrophy. It means that if patient is having severe aortic stenosis and with left ventricular hypertrophy, which is difficult to say that it is Hcm, unless patient is having the asymmetric septal hypertrophy. Like you can see sometimes patients of CKD with diffuse concentric LVH, we cannot label it as a case of the hypertrophic cardiomyopathy. These patients of hypertrophic cardiomyopathy, you have to rule out the other cause of the LVH. After that, you label them as SCM. The prevalence is 1 in 200 by 500. This is from the US study, not from the Indian study, and we may or may not find this prevalence. I feel this prevalence may be more, but less patients comes to our center because of the asymptomatic nature of the disease. Coming to the unique pathophysiology of the disease, we all know that most of the patients are asymptomatic and some patients are symptomatic. If I talk about asymptomatic patient, even patients of left ventricular outflow tract infection can be asymptomatic, and even patient of non-obstructive patient can be symptomatic. So what are the cause of who precipitate the symptoms of this patient? We all know that when patient when the thickness of the LV increases, there's increase in the left ventricle and diastolic pressure in long term. But initially what happened? LV EDV, that is left ventricle and diastolic volume decreases. So basically the volume decreases, and the other thing is that the left ventricle and diastolic with time it increases, so it cause the diastolic dysfunction. Second thing is the 70% of this patient have left ventricle outflow tract obstruction, which may be asymptomatic or symptomatic. Other thing is supply demand mismatch. We all know that type 2 MI are more common with these patients, and the arrhythmia, that is AF, is the worst arrhythmia for this patient, as it can cause the loss of kick of the left atrium and the worsening of the symptoms. So two diseases that worsen drastically with the AF is SCM and aortic stenosis. And these patients are very commonly missed in emergency, and they patient undergo angiogram 2 or 3 times in 1 to 2 years. This is what happens with I have seen 2-3 patients who had angiogram every yearly for raised troponin, normal LV, and these patients are diagnosed with SCM. So don't confuse it with the ACS. Every time we find T-wave, deep T-wave inversions, patient have NSTEMI, look for the previous history. Same ECG is there. It should come into mind that it can be case of the hypertrophic cardiomyopathy. Coming to the prevalence, if you think the left ventricle is commonly involved than biventricular, but with time, what we are seeing that the incidence of biventricular SCM is increasing. Right now, on 20-30% patients are biventricular SCM, left ventricle is involved in almost all the patients of SCM. Sometimes, very rare case report, we have patients of right ventricle SCM, but that they are present with some other clinical disease like CCPGA or something like that. So coming to this is the left ventricle outflow tract obstruction. You can see this 70-year-old female with left ventricle outflow tract obstruction. You can see that there is the increased surveillance across the left ventricle outflow tract, not across the aorta. And you can also see that it's a slight MI is also there. So this patient, you should rule out left ventricle outflow tract obstruction with aortic stenosis by putting the pulse wave Doppler across it. We have seen the patient diagnosed with aortic stenosis and diagnosed as a patient with SCM diagnosed as a patient of aortic stenosis, and they are planned for the tower outside. That should not happen at least in India, because with time we are finding more and more patients of SCM and SCM in our clinics. And you can see that this patient is having the left ventricular outflow tract obstruction of gradient of 75 millimeter of mercury. Then you can see the typical dagger shape that of the LVOT obstruction. So this case is a very interesting case. 18-year young boy who came with the history of syncope, and you can find it here that this patient is having the pre-excitation also. You can see that the PR is small and there is the slurring of the PR, slurring of the QRS, just your pre-excitation. So whenever you find the patient of hypertrophy. This is typical of concentric LVH, look like concentric LVH. Here you can also see that there is the right ventricle is also thick. So this is a case of biventricular HCM, and in long axis view you can see that is diffuse hypertrophy. I would say diffuse hypertrophy of IBS posterior wall along with the pre-excitation. Then two things should take immediately into your mind. First is like PRPK2 mutation, or second is a general disease. So what we did, we put the ICD in this patient in view of having this family history of sudden cardiac death along with history of syncope. In Holter, there was a long pause of around 5 seconds. So then this patient needs pacemaker, but due to having the diffuse hypertrophy and history of syncope, family history, we have put the dual chamber pacemaker in this patient. So coming to the history of SCM. Coming to the history of SCM, we should know our history of SCM. This is the father of myectomy, Andrew B.G. Marrow, and you should know about him that I would say Dr. Barnwell diagnosed the documented case of hypertrophic cardiomyopathy, and this guy is the father of myectomy, who itself suffered from having the obstructive cardiomyopathy and died due to the heart failure. Due to the genetic nature of disease, Andrew Barrow has 3 kids. 2 kids had SCM, 1 undergo myectomy, and 1 undergo cardiac transplant for it. And coming to Dr. Brownwell, who first labeled the patient of hypertrophic cardiomyopathy and hypertrophic cardiomyopathy, diagnosis was way ahead before it also. So coming to as a resident, we should read about the good history of Dr. Eugene Barnwell, who is the father of cardiology, and now I would like to say he's father of hypertrophic cardiomyopathy also. And in this, how he diagnosed SCM, it will be amazing to know that he diagnosed SCM clinically and cardiac cath, because echocardiography came in 1970. Diagnosis of hypertrophic cardiomyopathy was made in 1960. So what he did, the patient came to him with history of syncope, and then he diagnosed a case of the obstruction in the alveoli. He referred the patient to the surgeon. After steniotomy, the surgeon found no gradient on table, and what he did, he entered from the left atrium to the intra septum and from the aorta to the LV, and both his fingers meet inside the LV cavity and found no obstruction. So he said, Dr. Brownwell, that you referred the wrong patient to me. Similarly, after 6 months, Dr. Brownwell diagnosed one more patient of the SCM, referred to the surgeon. Surgeon did the same maneuver and found no obstruction. And called the Dr. Brownwell to the CTVS OT to find what is the problem with the patient. So Dr. Brownwell also found no gradient on cardiac on CTVS OT table. What he did, he asked the surgeon to put one cannula in the LV and one cannula in the radial artery, and then shift the patient to the outside the OT. And outside OT, after few months, patient again developed the gradient. So then he proposed the theory of dynamic LVOT. Means you cannot find gradient every time. Sometimes patient is dehydrated, you find the gradient. Sometimes patient is not dehydrated, the gradient cannot be there. So dynamicity of left ventricle obstruction is the hallmark. I would say that is the uniqueness of the hypertrophic cardiomyopathy. So coming to the what is the mechanism, why this patient has LVOT, that you should know that it is not the problem of the mitral valve. Mitral valve is normal in this patient. When there is asymmetric septal hypertrophy, you will find that there is increased contraction because of the increased hypersolic calcium increase in the muscle. So when there is increased contraction, the velocity across the left ventricle tract increases. It's not something rare or something unique in it. It's like sometimes when there's hypertrophy on one side and there's not hypertrophy, it contracts, definitely velocity increases. That velocity drags the mitral valve towards the LVOT. So with time you will find that There's MR should start increasing, and the typical MR jet of SCM is central or posterior military jet. It cannot be anterior jet. If you have anterior jet, it is not secondary to the SAM. It is most of the time the organic pathologies. Sometimes there is accessory papillary muscles are also there. So systolic anterior motion is the hallmark of SCM, but it is not always present in the SCM. In the SCM patient. Second, it is dynamic obstruction. Means sometimes you will be able to find it, sometimes you will not be able to find that obstruction. So coming to the history, now we coming to how the SCM was diagnosed, how someone diagnosed the SCM. First cases of the SCM were diagnosed by Dr. Donald, and what he did the autopsy of the patient, patient who died with sudden cardiac death, and found that there is increase in thickness of the interventricular septum, and he labeled it as a case of hamartoma. Hamartoma means it's like the normal tissue, essentially formation of the normal tissue. And he said that it's a tumor of the heart. And you can see it here also. There's bizarre appearance of the muscle. Normally, muscle becomes in the normal parallel fashion, but you can see it here that they are bizarre. Some are moving in this direction, some are coming in this direction. This is known as myocardial disarray. Then in 1968, Dr. Dornwall diagnosed the case of the dynamic alveolar. He didn't label it as a hypertrophic cardiomyopathy at that time. He labeled it as an idiopathic hypertrophic subaortic stenosis, and he diagnosed it on the basis of the cardiac extraction and clinical examination. There was no echocardiography at that time. So what he found that among 126 patients, 14 patients died, and among 14 patients, sudden cardiac death was more seen with familial idiopathic hypertrophic subaortic stenosis. So you should know that family history of sudden cardiac death is very important to label it as a case of a high risk SCM rather than to label all cases as high risk. This family history is really important to label it as the history that needs treatment for it. And 3 patients has sporadic and average age was 40 years. And 4 patients died. 4 patients died due to progressive heart failure. That is among 14 patients what he diagnosed, and that 14 patients, 4 patients died to heart failure, 10 patients due to cardiac death. And similarly, in the West, that is in the around other part of this other part of the ocean, the Dr. Swan team was diagnosing such patients of symptomatic post-prognosis hypertrophic cardiomyopathy, and what they found that among 95 patients, 14 patients died, and 6 patients died post-myectomy. That time the myectomy started increasing, and 2 patients died in post-op period. And sudden cardiac death was seen in half of the patients. And they found that the annual mortality was 2 to 4%. Then comes the era of the echocardiography. Then in 1985, the real change in the thinking of the hypertrophy came when this from the Spirito group from the Italy. This authors are from the Italy, and they found that in OPD patients, diagnosis of the patient who diagnosed in outpatient department, there was 0 death. So what they found that the patient who comes in the emergency with heart failure, their prognosis is different, and that the routine garden variety of SCM, and they labeled it relatively stable disease rather than what we thought before it that it is a disease with 2 to 4% annual mortality. That is very high. Then you should know this guy. This guy is one of the best intervention cardiologists. He is known as the Siebert, Ulrich Siebert, and he first did the alcohol septal ablation in 3 elderly in 1994. Myectomy came in 1960s, and alcohol septal ablation came in 1994, and all 3 patients reported a significant benefit on first day of treatment. So there's a large history of it. It's not easy for him. He did all his faculty position at Switzerland. However, the local committee of Switzerland rejected his plan of temporary occlusion of the septal artery. Then he left the country. He went to Royal Brompton Hospital in 1992, and then he gave